Do you see it?
I don't.
Okay, it says it's streaming again. Oh my God. I mean,
We're good. Yes. Hi, good afternoon. My name is Alana Foichter, and I'm the Senior Manager for National Programming with NOCC. For the last several months, we have been hosting our Ask the Expert series to educate survivors and caregivers on issues related to their care and well being. With September being Ovarian Cancer Awareness Month, we thought it might be time to broaden our audience to anyone who is interested in learning more about ovarian cancer. Today, I am so pleased to have Dr. Stephanie Wethington, Director of the Susan L. Burgett Gynecologic Oncology Survivorship Program and an assistant professor in the Kelly Gynecologic Oncology Service of Johns Hopkins Medicine. Dr. Wethington completed a fellowship in gynecologic oncology at Memorial Sloan Kettering, and before that, completed her medical degree and residency in obstetrics and gynecology at Columbia. Thank you so much for sharing your time and expertise with us today.
Hi, everybody. Thank you very much for having me. I'm excited to be here.
One quick note, for those who are watching, we encourage you to use the chat box below to ask questions, and we will try to answer as many as we can. So we'll get started with the basics. Dr. Wethington, can you please explain what is ovarian cancer?
Absolutely. I think it's actually such a simple question. And sometimes people are like, why do we have to start with such a simple question? But it has over the years become a little bit of a misnomer. The ovary itself is a place that likes to grow tumors and is ripe for growth of tumors. And historically, we've labeled ovarian cancers as cancers that we thought arose in the ovary because that's where the largest volume tumor was. And we now, through the sort of beauties of molecular profiling, have come to understand that ovarian cancer comes from the ovary in some cases, and in other cases, it actually comes from the fallopian tube. So when we use the word ovarian cancer, we're referring to tumors that actually do come from the ovary. Those we sometimes call sex cord stromal tumors or germ cell tumors. Those are two types of cells within the ovary that can become cancerous. And sometimes when we're thinking about those epithelial ovarian cancers, we're also including those high-grade serous ovarian cancers, and those most likely arise in the fimbria of the fallopian tube. Because the fallopian tube is open, those cells drift down, land on the ovary, and grow into tumors that look, when you look with your eyes and not under a microscope or not in the lab with the aid of molecular technologies, that look like ovarian cancers. So when we talk about ovarian cancers, we're including three big categories: epithelial cancers, sex cord stromal tumors, and germ cell tumors. And we're also in that epithelial category, including high-grade serous fallopian tube cancers / high-grade serous ovarian cancers, and then also a group that are labeled primary peritoneal cancers, because sometimes when we go in to operate, we find the primary largest tumor on the peritoneum, or perhaps somebody has a few years in the past already had their ovaries and fallopian tubes out, and so we can still get that primary peritoneal cancer. So it's one word that describes many different things in what it encompasses.
Thank you. I think that's very clarifying. How about what are the symptoms of ovarian cancer?
Yeah, so the symptoms of ovarian cancer can actually be very vague. That's the challenge in all of this, because most women who develop ovarian cancer, when you ask them about their symptoms, will cast back and remember things like bloating, getting full easily, new abdominal or pelvic pressures, a new underlying little bit of nausea that persists, maybe a change in urinary function or bowel function, meaning having to go to the bathroom more frequently than in the past, or when they go to the bathroom, having a little bit more of a challenge. These are all symptoms that I think every woman has had now or then, probably in the last month. So we do make a distinction when we talk about these symptoms. It's not a one-off, but if you have these symptoms persistently for 2 weeks and they aren't quite going away, that's when we would start to think, is this a sign of something else? And potentially one of the things on that list of something else's is ovarian cancer. And that's one of the challenges, is that it's vague symptoms that could be attributed to a lot of things.
So let's say a woman is experiencing some of those symptoms. What kind of doctor should she see?
Yeah. So you definitely want to start, the first doctor, I would say, depends a little bit on a woman's environment. Some women have a gynecologist who they are very close to, or are seeing a gynecologist, and that is actually who I would choose first if I had my pick of who you see first. But certainly a primary care physician should be aware of these symptoms and aware of the workup. So depending on your individual circumstances and who you have a relationship with, because that's who you're going to be able to get in to see the fastest, either your primary care or your gynecologist. And if both are equal opportunities in terms of access, I would actually start with the gynecologist.
Great. Speaking of the gynecologist, one of the myths about ovarian cancer is that the annual PAP checks for it. It doesn't, although I did read an article this week that was saying perhaps it might in the future. How does someone get diagnosed if they're at risk or have symptoms?
Yeah, so I think that, as you note perfectly, we do not yet have a good screening test. So I'm going to make a distinction and kind of clarify what is screening. Screening is looking for a disease when someone has no symptoms. So you're taking someone, we're going to use that label that's normal, asymptomatic, has nothing going on, and you're looking to find the disease. And the goal of screening is to identify the disease early, before it becomes advanced, so that you can impact the outcome of the patient or the person / patient and person, as opposed to a setting where you have symptoms. And when someone has symptoms, let's say they present with the bloating or they present with new pelvic pain, the workup is in some ways directed towards those symptoms. So perhaps an ultrasound, for instance, that's one of the first things in gynecology that usually is started with, is an ultrasound to make sure everything in the pelvis looks good if you have pelvic pain or postmenopausal bleeding or something like that. So in the symptomatic population, there's a variety of tests and the doctor will make a determination, maybe an ultrasound, maybe a CT scan, maybe there's something in the history that leads down a different path other than a GYN cancer path. So there's a lot that can be going on, but certainly starting with clarifying what are all the symptoms, and often for this, some sort of imaging. As you referenced, the pap smear. Pap smears are a screening test, and included in the pap smear in 2020 is both what the cells look like under the microscope, that might be called cervical cytology or cytology, what the cells look like, and also HPV testing, and that's viral testing. And those two components screen for cervical cancer. And it is often a misunderstanding that they screen for endometrial cancer and or ovarian cancer. And to date, a pap smear is not an adequate screening test. And that's because it's looking for these two things, the cytology, what they look like under the microscope, and the HPV. And neither of these, in the case of ovarian cancer, are usually present in sufficient numbers to capture them on a random pap smear. So what you may perhaps have read about is there are a number of studies across the country looking at, can you make that pap smear extra special with molecular profiling? So can you do any sort of molecular assay, maybe sequencing, maybe looking for specific targeted mutations? Can you do any sort of assay on that pap smear to pick up mutations that may, or molecular abnormalities that may reflect an ovarian cancer, and therefore alter the utility of the pap smear? And so there are a number of institutions asking this question and trying to get at how can we improve screening for ovarian cancer, because right now we don't have an adequate screening test.
And hence women are typically diagnosed at later stages when the prognosis is not as good.
That's exactly right. That's exactly right, because it actually takes a lot before women get symptomatic.
Right.
So that's very true.
Maybe you could talk a little bit about some of the risk factors and what someone might do if they are at a higher risk.
Yeah, I think probably the most important thing is sort of knowledge of your family history. And the reason I say that is because one of the most prominent risk factors for ovarian cancer is a family history of cancer. We think of ovarian cancer and breast cancer as being two of the family histories that we most focus on. And that is because the incidence of BRCA1 and BRCA2 mutation in women who have ovarian cancer is the highest hereditary or family linked risk factor. So that's always sort of the buzzwords and where our minds first go. But you'll notice when you see your doctor and you say, I'm worried about family history and my risk of ovarian cancer, your doctor's also going to ask about other cancers, colon cancers, pancreatic cancers, endometrial cancers, because perhaps there are other syndromes or other hereditary factors that might influence your risk of cancer. So it is a family history in general, with a particular focus on breast and ovary, but not only a focus on breast and ovary, would be the biggest risk factor that I would start by focusing on. There are also other risk factors, certainly. The ever-present smoking risk, which for many cancers, whether or not you've had any children, having your tubes tied, actually tubal ligation actually decreases your risk. So when you think about increase and decreasing risks, that decreases your risk. And that again goes back to that idea I mentioned that it's linked to the fallopian tube, those high-grade serous ovarian cancers. So these are some other factors to consider.
Excellent. So you're a perfect example, but maybe you can tell us a little bit about the kind of doctor that treats ovarian cancer.
Yeah, so once you've had that initial workup, you had symptoms, you went to your doctor got an ultrasound, maybe there's a mass on one of the ovaries, for instance, probably the most common initial thing found on imaging. So there are different physicians who take care of individuals with cancer. Gynecologic oncologists are unique. We are the only oncology specialty that still does the entire spectrum of chemotherapy and surgery. We don't do radiation ourselves, but we do chemotherapy and surgery. And because ovarian cancer relies upon a combined strategy to treat it, there is a body of literature that has shown that it is advantageous to seek the care of a gynecologic cancer specialist or a gynecologic oncologist when you're diagnosed with an ovarian cancer. And so I would advocate, and it's not just professional advocating because it's my specialty, but I think at this point there's enough literature to support that you want a gynecologic oncologist involved in your care and helping to develop the treatment plan from that initial first finding that leads you down the path of finding out you have an ovarian cancer. So I say that to mean I wouldn't necessarily wait until you've had surgery and you have a pathology report to seek that gynecologic oncologist. If somebody says to you, you have imaging that's worrisome, you want to involve the gynecologic oncologist from that first moment because they can help with identifying the best path forward. And so in some care settings, there are numerous gynecologic oncologists available. If you came to Baltimore, for instance, where I am, there's many of us. In some care settings, there's a small number. And so the role of the gynecologic oncologist is a sort of organizing role in some care settings. They provide the care themselves, but they may also work with medical oncologists, for instance, who give the chemotherapy themselves. So I want to clarify, you want to involve a GYN oncologist, but in some care settings, it's not possible to have the GYN oncologist do everything. And so there are other collaborators, and all those collaborators are very important.
That's helpful because I oftentimes will talk to women and sometimes they'll say they're seeing a medical oncologist. And then other people say, well, wait, you should be seeing a gynecologic oncologist, but they might be in partnership together.
That's right. And so it's very important to know where you are and what the setup is for your disease. But I would say always we would strongly advocate making sure that there's that partnership and that you understand how that partnership works. And so that's very important for the care.
Okay. What about the survival rate for ovarian cancer?
So this is one of those things that all of us who take care of women with ovarian cancer are strongly focused on finding ways to improve the survival rate. And I would say, if you go back to when I was a resident, and my kids always like to joke with me now that I have many gray hairs, so I say these things and it looks like it was a long time ago now. But if you go back to when I was a resident, we had very limited number of treatment options. And in just my career and just what I consider from a medical or an evolutionary standpoint, a very short period of time, we've seen, particularly in the last 4 years, a complete shifting where I would say there's a lot of room for optimism. So when I started as a resident, as a trainee, we sort of had a limited number of drugs. Paclitaxel was the last blockbuster regimen. Then we had the introduction of intraperitoneal chemotherapy, which for a while was considered sort of a blockbuster. And then we've had other medications or other chemotherapy agents that came on the market. But it wasn't really until the last 4 to 5 years when we've had the introduction of PARP inhibitors. And we've come to better understand the role of bevacizumab, that we've really seen this hopeful landscape of being able to shift our survival curves and seeing improvement in how women are doing. It doesn't mean there's not still a huge unmet need and once this cancer comes back, it becomes a chronic disease. So we still need more. We're not satisfied with what we have, but we've seen a huge hopeful jump in our armamentarium, in our understanding of the disease. Even as I mentioned, when I started in training, it was ovary cancer, and now it's fallopian tube cancer, and we understand the mutation profile, and we understand how many people have inherited BRCA mutations, and how many people have tumors that have BRCA mutations, and how many people have an abnormality that affects the way the BRCA gene functions in our bodies, and that's sort of the pathway that leads down to the cancer developing. So we have all this new information that is really remarkable. So I would say prognosis today, whereas years ago I would have given you a number, but I would say today is I actually don't sort of know what the prognosis is, because I think we have a new prognosis that hasn't been completely laid out yet. And I have true, legitimate, not Pollyannish hope that what we're going to see in the next 5 to 10 years is that I'm right. And I can't predict today what the prognosis is going to be for women who are diagnosed today, because we've shifted our outcomes. So that's how I would answer the prognosis.
I love it. That's helpful. What about for women who don't have any kind of mutation or any kind of tumor abnormality? Are there opportunities for them?
Yes, and actually, some of the newest data in PARP inhibitors has been focused on sort of not distinguishing BRCA mutations from women who don't have BRCA mutations, and also looking at combinations that may be more beneficial for women who don't have BRCA mutations than for women who do. So I would say what's happening is, and I probably should stop using the phrase BRCA mutation and start using the phrase HRD. So when we talk about BRCA, what we're talking about is a mechanism by which DNA is repaired. And it's more complicated than just BRCA. So I probably shouldn't say BRCA, I should say HRD. And that HRD encompasses BRCA as well as other mechanisms. So what we're coming to understand and be able to sort of divide up is, yes, differentials in benefit, but also differentials in treatment paradigms. And so I think, although there is a lot of focus on this HRD population, we are starting to elucidate similarly where these drugs and in what combination these drugs are going to be helpful for women who do not have that HRD profile in their tumor. Yeah, for sure.
A lot of information. Thank you. I'm going to go to questions now, but I did have one that someone had asked ahead of time. And this was, if I am at risk for ovarian cancer, how do I best advocate on my own behalf?
So I would say if you're at risk for ovarian cancer, then the best way to advocate is really to have a frank conversation with a physician. And I would hope that whoever your physician was would be able to either help you set a plan or direct you to someone who can set the plan. So for instance, if you have a gynecologist, some gynecologists feel very comfortable with the risks. Some might say, go see this GYN oncologist and have a consult, or go see this genetic counselor and have a consult. And genetic counselors have a wealth of information and are really good at talking through what is the risk and what should your individual plan be based on your risk. For women who have known inherited mutations like BRCA1 and BRCA2, the recommendations are for risk-reducing surgery. And the details of when to do those surgeries are based on your family history, any plans for pregnancy, and exactly what mutation you have. But certainly for anybody with an inherited risk, that risk-reducing surgery, close consultation with a genetic counselor, with a GYN oncologist, and maybe with other types of doctors like a breast surgeon or a breast medical oncologist, or perhaps if there's a link with colon cancers or other cancers, other oncologists. But a well-developed plan based on your mutation is important. So if you know you're at risk, it is absolutely critical to gather the information, define the risk, set the plan based on the risk, and know that for many women who are at high risk because of inherited mutations, surgery to reduce that risk by removing the fallopian tubes and ovaries is absolutely critical.
And is there a time frame for that?
Yeah, so the time frame depends on which mutation you have. Women who have a BRCA1 or BRCA2 mutation, we target a little bit younger, perhaps 35 to 40, or when you're done with childbearing, if you've BRCA2 mutations, 40 to 45. Lynch syndrome, which is the syndrome that's linked to colon cancers and endometrial cancers. That's another area where we've really, in the last 5 years, come to much better understand the risk based on the individual gene that is involved. And so in some cases there's increased risk of ovarian cancer. In some cases, as we're figuring things out, it looks like maybe not. And so those guidelines are more nuanced. The other thing I will say is all the age guidelines get altered if you have a family member who is diagnosed at a particularly young age. So if you have a family member who was unfortunately diagnosed with an ovary cancer at 35 or 40, the opportunities, the options, the discussion may be a little bit different than if your family history is more reflective of the average. And the average age of diagnosis is about 61. So 61 for the whole population in terms of average age of diagnosis.
That was one of the, I'm looking at some of the questions, and someone said that they wanted us to point out, Twyla, that another myth is that you can be too young to have ovarian cancer.
Yeah, you can't. And actually part of the reason I think probably, although not definitely, part of that misunderstanding comes from the fact that, and even I do it for those of you listening who know about ovarian cancers, we start talking about ovarian cancers and we slip into really talking about those high-grade serous fallopian tube, ovarian, primary peritoneal. And what ends up getting sort of, because that's the greatest in terms of number, what ends up getting left out a little bit are those germ cell and sex cord stromal tumors that I mentioned at the very beginning, which do tend to happen in younger women. And even those high-grade serous can happen in younger women also. So I don't want anybody to think they can't, but certainly those other two types, those germ cell tumors and sex cord stromal tumors, can also happen in younger women. So it is a disease that affects many ages.
Okay, looking for some more questions. Give me just a second. I have a lot of, yes, that's what happened to me. My doctor wouldn't listen to me.
Yeah.
Sorry.
I think sometimes while you're looking, Alana, I'll just say, I think sometimes that, because remember I mentioned the symptoms are so vague. I think sometimes the message that you're trying to convey, that a patient is trying to convey, doesn't come across because the symptoms are so vague. And that's where I think on my end, and many GYN oncologists feel that part of our obligation is to raise awareness and to talk about this in as many forums as possible, so that when women have those vague symptoms, they've heard this idea before. And so when they go in and seek the care, they feel empowered to say, 10 years ago, I heard someone mention this thing, and could this be what's going on? Which often can be hard to, often I think sometimes people are intimidated to bring those things up. But I think the vagueness of the symptoms, the actual rarity of the disease, right? It's, ovarian cancer is the second most common gynecologic cancer in terms of number of new diagnoses. It's an easy number to remember. It's about 25,000 cases a year. It's not a large number of women. It's a critically important entity, but so I think a lot of times it doesn't fall on that provider's top of the list. And so it's why I think a lot of us hope that if we, distribute the information, speak out, make sure women know, that will actually be an empowering way to affect leading to that diagnosis a little bit faster.
That was one of the things for us to do this was to educate women who maybe don't know as much about ovarian cancer. With COVID, it's really hard to get out in the community and share that information. So we're looking for other opportunities. This wasn't necessarily a question, but it raised the question. So Wendy said that her mom passed from ovarian cancer at 62. She tested negative for BRCA, but has a very strong family history. Mm-hmm. She says she's now 55 and am having symptoms, and we'll be seeing a gyno soon. For those people who have a strong family history but don't have any genetic mutation, what should they be doing?
Yeah, this is where I feel actually like a genetic counselor can be very helpful, because they'll be very good at helping to sort through the issues. And sometimes there's unusual genes at play, and that's where the genetic counselor can be helpful. And sometimes it's just that our technology hasn't quite figured out what's going on. And sometimes maybe there isn't a hereditary element, but the risk element is then a discussion with your doctors and a shared, the terminology for today is shared decision making. I just mean that to say a reasonable discussion of the risks and benefits of different options. So perhaps someone has a very strong family history of ovarian cancer and they have a conversation with their physicians and they decide that moving forward with risk reducing surgery is how they want to proceed. That can be a reasonable option. Someone else may have a family history that's not quite as pronounced, and they may decide that they want to move forward with, imaging and CA125, which is, I don't want anybody to think that that is, as I said, we have no screening test. So that is not adequate, but that may be a middle ground between surgery and not moving forward with any sort of intervention or increased surveillance. It may be that someone's real young and they know they have this family history. Let's say they're in their 20s or 30s, and actually birth control pills may be one option for reducing risk. And I say maybe because you always want to check with your doctor and make sure that you don't have any contraindications to birth control pills. There are a small number, and so you want to be sure you do it under the care of a physician who's comfortable with them. But it is well established. So the not maybe part is that using birth control pills to suppress the ovarian monthly cycles does affect the eventual risk of ovarian cancer. And so there may be other things that one could consider along with surgery that could be impactful that one could employ and why it's important to discuss. So there are definitely situations where even in the absence of a known documented mutation, we do move forward with surgery, and it's an individualized decision.
Rick said that he lost his wife to ovarian cancer at the age of 52 and is worried about his kids. I keep sending them to doctors to start monitoring, but the doctors keep brushing us off. How can I get their attention?
Yeah, I think that depends. I don't know how old Rick's kids are. So it may
23 and 22.
23 and 22. So I will say at that young in age, there is no intervention, and I wouldn't necessarily advocate at that young an age ultrasounds or CA125s or increased visits with the gynecologist or a visit with a GYN oncologist. If they were in their 30s and 40s, I think some of the key questions are, was the person who was affected with cancer, that's the incident case in doctor speak, was that person tested for the panel of mutations we know can cause ovarian cancer, and were they positive or negative? So that's like a first question that the answer to that may be leading what's happening. It may just be the age. And I think at such a young age, even with a family history, most do not recommend early ultrasounds and CA125s. Now, in the case where no genetic testing was done of the person who had the cancer, or we don't have that results, or that person was positive, then it's certainly a discussion about when to test the younger relatives, the children. And so that becomes a discussion with the children, because they obviously are the ones who consent to the test about what they want. And then and sort of strategizing when the optimal age is. And some people want to be tested the minute they possibly can be tested, and they want the information sooner rather than later. And some people do decide that for them, they want to have the test done when they would then start changing their treatment or changing their management plan based on the results, and they don't want to know until that point. And so setting a plan that's good for each individual person is important. And I want to add one other thing. I don't know, you may have said it, but it went right out of my head. I don't know whether these children were male children or female children. And it doesn't matter. If you have an inherited risk of cancer in the gynecologic cancer realm, other diseases are different, but in the gynecologic cancer realm, the inheritance of that abnormality is not based on whether the child is born a man or born a woman. It's actually based upon the 1 in 50 risk that the gene would be passed on. And so it's not considered X-linked or sex-linked inheritance patterns. And so you would still want to get tested even if you were male, if you were the son of a woman who had ovarian cancer, or the daughter. And the implications are different, but the testing is equally important. Male children can pass it on to their children, and there are some other cancers associated with these genes. So I always am certain to emphasize to people, when we take the history, we take both the paternal history and the maternal history. And when we counsel women on what information they should share with their family, we're always real careful to counsel that the information is relevant for all children and all siblings, brothers and sisters, and not just female children or female siblings.
That was great, because we did not talk about that earlier, and that is a super important part. Someone asked, if you are postmenopausal, is there any benefit to removing the fallopian tubes to reduce risk?
So this is a great question, and at this point in time, my answer is not unless you're having surgery to have your uterus removed for some reason, and then certainly, frankly, I would recommend that anybody who is having a hysterectomy strongly consider / I strongly recommend having the fallopian tubes out at the same time. And that is because, as I mentioned, of this risk that the fallopian tubes are linked to the risk of high-grade serous ovarian cancer. And once you take the uterus out, you don't need the fallopian tubes anymore. So that would be true for postmenopausal women or premenopausal women. Whenever you have a hysterectomy, please ask your physician, your surgeon, about also removing the fallopian tubes. Then when you get to postmenopausal women, we would not recommend electively doing surgery solely for the purpose of removing the fallopian tubes or removing the ovaries. I think in the future, there are a number of exploratory studies looking at a very interesting question, which is if you're having surgery for some other intra-abdominal process, let's say you're having your gallbladder out, for instance, that's the easiest one, and that's the study that's already published. What about removing the fallopian tubes at the same time in order to decrease your risk? And we're not there yet. So it's a very insightful question. The currently available information applies to anybody having a hysterectomy. And I think, and in the future, it remains to be seen what we do in terms of electively removing the fallopian tubes at the time of other intra-abdominal surgeries.
That makes sense. I'm going back to one of your suggestions, which was to put a girl at risk on birth control.
Yeah.
And the question is, how early should that start?
Yeah. So we don't.
I'm sorry. And how long after does the benefit last?
Yeah. So the benefit does seem to last. And once you hit 10 years of use, the benefit sort of, in my understanding, plateaus a little bit. So that 10-year use mark is important. And so there is no earliest age, but I certainly think, I wouldn't in a 15-year-old, for instance, but, as women get a little bit older in their 20s and into their 30s is the time I would more target.
Okay.
It's a good question.
Oh, okay. Can non-inherited become inherited with future children if fertility is preserved? I'm not sure I understand that question.
So I'm not sure I do either. I will tell you the common scenario for inherited. Well, let me actually take a step back. I talked about inherited risk, and I want to add one thing actually. So I don't think this is what this person is getting at, but I'm going to deviate and answer what I think is a very important question. Every single woman diagnosed with an epithelial ovarian cancer should be, this is guideline endorsed, this is not a me specific recommendation, this is the current 2020 standard of care. Anybody diagnosed with epithelial ovarian cancer, fallopian tube cancer, or primary peritoneal should have genetic testing. And that testing should include at a minimum BRCA1 or BRCA2. And the newer guidelines also recommend panel testing even, recommend slightly less vigorously than the absolute necessity to have BRCA1 and BRCA2 testing. And so that holds even if you have no family history of ovarian cancer, because there are women who have no family history whatsoever who have inherited risk. And sometimes the parents are still alive, and so you can go back and test the parents, and then you can figure out which side it came from. And sometimes they're no longer living, and so it's not possible to do that. But the need for genetic testing in the setting of epithelial ovarian cancer exists regardless of family history, because we know that risk profile is there. So I don't think that's what they're getting at, but it is possible to find out that you had hereditary ovarian cancer without knowing before you developed the cancer that that gene existed in your family. And the genetics term for that is penetrance. So these inherited mutations do not have complete penetrance, meaning everybody who inherits it does not develop the disease. It's why with the BRCA1 mutation, you don't have a 100% risk of getting ovarian cancer. Family history matters, but maybe it's closer to 40%. If you have a BRCA2 mutation, you don't have a 100%, it's actually about 20%. So it's not a definitive that having these genes, you will get the cancer. It's that your risk is increased above the about 1.6% baseline risk in the population. So hopefully that answers the underlying question in some way. But those are some important information pieces.
Someone asked, what can you tell us about clear cell carcinoma?
Yeah, so clear cell carcinoma of the ovary is another epithelial ovarian cancer. It's rarer. It's one of the rarer ovarian cancers. It seems to have a different clinical presentation. So when you talk about the high-grade serous ovarian cancers, those are the ones that like to spread all over things. It's like somebody took a bag of sand or a bag of rice and dumped it into the abdomen, and the granules landed all over the tissues. That's often what we think about as the most common presentation of a high-grade serous. Clear cells actually tend to stay ovary confined for much longer, and you're more likely to have a larger mass without having spread when it's found. And we're similarly beginning to understand more of the biology or the underlying mechanisms. There is a signal that it could be related to endometriosis in some cases, and then spontaneous changes in others. And so when clear cell carcinomas do behave very differently. So there's the molecular biology of them, and then sort of the phenotype, or what we as physicians see in our clinical experience. And so they are a different cancer than the high-grade serous, and much less common.
Heather writes that she was diagnosed concurrently with ovarian and uterine clear cell. Does this change the normal protocol?
Yeah, so those what we call synchronous or concurrent diagnoses can be very complicated. I don't know how old she is, but we see that more commonly in younger women. So that when we hear that, often we think if we're playing the odds, so to speak, that this could be a younger person. And what we do when we have concurrent diagnoses is we look at the treatment for each part. So what is the treatment that the uterine part needs? What is the treatment that the ovarian part needs? And where they overlapped, do they both need chemotherapy? Carboplatin and paclitaxel being our favorite in GYN oncology for first-line treatment of cancers. Maybe they both need 6 cycles of carboplatin and paclitaxel. So there's nice synergy there, or nice alignment, not synergy, nice alignment. And so then you can do that one treatment and cover both diseases. It is also possible that the ovary would require 6 cycles of carboplatin and paclitaxel, and the uterine would require some radiation therapy. And so then you do a treatment plan that incorporates both of those. And actually, it's a good question because it's not only simultaneous diagnoses of 2 different GYN cancers that can happen, but we see not infrequently simultaneous diagnoses of a breast cancer and an ovarian cancer, or of a colon cancer and an endometrial cancer, or a breast cancer and an endometrial cancer. And even that example, the breast and endometrial, I give a little bit because those are probably not related through a hereditary mechanism, but just those are 2 of the most common cancers and that women have. And so just by happenstance, you will sometimes get them simultaneously. So simultaneous or synchronous cancers can happen not infrequently, and you have to alter the treatment modality based on what each disease needs.
Can PARP inhibitors and immunotherapy have an effect on brain mets, or is this is very personal. I think we'll wait on that.
We'll wait on this, yeah.
There's a lot of, thank you to all of our followers, because there's a lot of comments out here. So there's obviously a lot of interest. I'm just trying to see where the questions are. A lot of instances. Okay, wait, here's one.
Okay.
Had my ovaries removed 10 years prior. In August, someone did a transvaginal and thinks there might be cancer. Her grandmother died of ovarian cancer. She's saying, who should I see? Where should I go? And obviously this is, I contacted a well-known hospital, but they didn't know if I should see a GYN or GYN oncologist. This goes back to what you were saying.
It goes back to what I was saying. And I would say if the imaging, this is where I don't think there's any controversy, and I'm not just advocating for my own specialty. I think this is a great example, perfect example of where seeing a GYN oncologist first would be ideal. So if you have an imaging study that says suspicion for ovarian cancer, that is a moment where engaging the assistance of a gynecologic oncologist to set the treatment plan and determine what should happen next is most important. It's always important, but this is the key moment when I would strongly recommend actually reaching out to a GYN oncologist. So I think in that case, you can call said hospital, whichever it may be, and say, connect me to your GYN oncology department. And you can say, I have an ultrasound that raises concern for ovarian cancer. I need a gynecologic oncologist. And at almost all institutions, that will be enough. You've said all the buzzwords and the appointment will be made.
Gina writes that her sister passed from ovarian cancer last September, and she had genetic testing and didn't show anything. She wants to know if this means she has an average risk or a higher risk.
So the data in this setting, we're starting to redo a little bit because we want to take into account women who had a family history where we may not have known about a genetic mutation. So in past times, we would have said, yes, anybody who has a family history has a risk. And now we're starting to separate out risk because of genetics and other risks. So there is an above average risk. It is not as high as if your sister had a known mutation, but there is a slight increase in the risk. And I think in this setting, it's a good moment to start with your GYN, talk to your GYN about their comfort with these issues. And if they're not comfortable, who they would refer you to make a plan that suits you and feels comfortable to you.
A woman who had germ cell is now expecting. Congratulations, Kate. She's wondering if her children are at risk.
As far as we know at this point, I mean, I don't know the details of your germ cell, right, but most likely no.
So mostly it's the serous carcinoma. Okay, that's hereditary.
And it's those epithelials. So even the endometrioids get genetic testing, for instance, or the clear cells. So any of those epithelial ovarian cancers, we recommend genetic testing for. The germ cell and the sex cord stromal at this point, that it's not the standard guideline.
Wow, I'm sorry, I keep going through here. I'm excited that we've had such a following here. There's just question or comment after comment. It's fabulous. I'm so glad that so many of you have tuned in. Let me see. Regarding monitoring after treatment, and while NED, I am getting routine PET scans and CA-125 every 3 months. Allergic to CT contrast. Yeah. Insurance company denies the scans. What is the recommendation for this?
So this is a very good question. And I would say it's an area where we all get into debate. and where I think every GYN oncologist, not every, but there's variability. If you, anybody who's my patient knows I sometimes use if you visit 100 GYN oncologists line. So if you visit 100 GYN oncologists and say, what is the follow-up for my ovarian cancer after I've been treated and I'm in remission, you're going to get like 101 answers is my joke, but there's probably 5 to 8 different ways that people will frame their recommendations. So what are the things you can use to screen somebody for recurrence? You can use symptoms, you can use the CA-125, you can use the exam, or you can use imaging. And so you have 4 modalities or 4 mechanisms to assess how suspicious you are for recurrence. And in some ways, I sort of think of the CA-125, the exam, and the symptoms as your initial assessment, and the CT scan as the confirmatory entity, right? So the CT scan in general, or the imaging study, CT or PET, sort of kind of trumps the others. The guideline recommends the physical exam and the symptom screen, and actually sort of places into a in-between indeterminate, I should use the word indeterminate category, the CA-125 and the imaging, which is why your insurance company then says, we're not going to pay for routine imaging. So many providers advocate for routine imaging because it is another way of assessing, right? It's more information, and it tells you what's going on inside that perhaps we can't feel on exam. Biggest structure I would say that applies to is lymph nodes, for instance. I can't feel your lymph nodes that are running up and down in the center of your chest, right, on your exam. So lymph nodes are one good example, and often lymph node is asymptomatic. So I think sometimes when people talk about why do we get the CTs, sometimes that is what's cited. And so the guideline, the symptoms and the physical exam are the elements included, plus minus CA-125. And the reason the CA-125 lands in a plus minus is that there is actually a randomized trial that says that following the CA-125 leads to earlier diagnosis of the recurrence, more lines of chemotherapy, but does not change overall survival. And so, so that's why some people question whether or not CA-125 should be used. That's why many women have a different follow-up plan, and there's no single follow-up plan. And I suspect this is, the insurance company is grasping onto the minus part of the plus minus for imaging, as opposed to the plus part, which is what the physician is recommending. So it's a tricky subject. Just going back to how we don't have anything good to screen in the recurrence setting, we have options for how to identify recurrence, and none of them is perfect. And so the question is, what combination do you use, and when do you use the different elements?
I have just a few more quick questions for you, maybe quick. How soon after surgery would you suggest starting treatment?
Yeah, so that's going to depend very much on what surgery, what underlying medical conditions, whether there were any challenges after the surgery. Perhaps there was a skin infection, perhaps a urinary tract infection, perhaps some people go back into the hospital after surgery because they get nausea and vomiting. Another term for that is an ileus or a small bowel obstruction. So there could be a number of things that happen after surgery. And that also then depends on the chemo regimen that you're getting. And so in general, we want to target, about the 4-week mark plus or minus. That's a general target that many people use. Certainly we don't want to go too far out. And if you think about it as a clinical trials question, most clinical trials want you to start therapy within 8 weeks of having the surgery or having the prior intervention. So there's no single answer. It's going to be individualized. But by and large, most people target by the 4-week mark.
Excellent. I think we might have answered all the questions. There's a lot of comments from many people, either who have had ovarian cancer or who have had family members that are clamoring for more earlier awareness. Do you have ideas on how we as advocates as patients, as family members, can increase knowledge about ovarian cancer?
Yeah, I definitely, it's something I spend a lot of time thinking about and talking about. I think we have a unique opportunity in a couple of arenas. So one, social media. Social media is a mouthpiece to speak your mind, and it can be used for good. And I think this is a moment where it can be used for good. So September is Gynecologic Cancer Awareness Month. So, I think many of us, our Facebook feeds, our Twitter feeds, our Instagrams, I think I hit most of the social media opportunities, are filled with awareness and raising awareness. Here locally in Baltimore, actually, someone went to this city and asked them to light up City Hall in teal in honor of ovarian cancer or Gynecologic Cancer Awareness Month, but also very specific to ovarian since it was teal. And so I think like looking for opportunities to do such a thing in your local community is very important. And then I think that social media just gets the word out. And I think there are a lot of, Facebook groups or people to follow on Twitter who are raising awareness about these issues, putting information online about new studies. And so I think sort of liking their posts or retweeting or sort of amplifying the voice makes a big difference. I think there are a lot of really good organizations that are out there advocating for patients and advocating for awareness. And so I think whether it's your local community organization, a national organization like NOC, there's a variety of opportunities to engage with those organizations and support those organizations. And that raises their ability to speak loudly. And so I think that organizational involvement and finding the organization that fits you and your personality so that you can really devote and amplify is very important. And so I would say those are some of the main things. All of these organizations also spend time each year as one activity, advocating in governmental forums. So going to the office of local mayors, of statewide governors, for instance, or the statewide senates or house, or even down here on Capitol Hill. And so I know that advocacy, raising awareness in the broader policy setting community is very important. And certainly for ovarian cancer, it's been revolutionary. I mean, I think the organizational infrastructure that is led to asking Congress each year to maintain funding for ovarian cancer research through the Department of Defense. Little known fact, the largest single source of ovarian cancer research funding in the United States government is the Department of Defense. And every year, NOC, SGO, a number of organizations go down to Capitol Hill and say, hey, you've got to keep this. This is like super important. And I think that's another opportunity. So I think there's a lot of opportunities, all of which come down to one fundamental thing, which is that we've got to talk about it. For a long time, nobody talked about this. And it's a sensitive subject because it kind of sits below the belt. But it's a super important subject and very important that we talk about it. And it's the only way we're going to shift and continue to shift the paradigm, because the reason we've made the progress we've made is because of the advocacy and the talking that led to the research support that led to our current innovations. So.
Yes, absolutely. And I hope that those of you who are out there watching who are not already involved with an NOCC chapter get involved. And if there's no chapter near you, then we'd still love to have you participate at the national level. I do want to give a small little plug because it is September. We are having our Together in Teal No Boundaries, and I encourage anyone who isn't registered for that also to go check that out at runwalk.ovarian.org. And one other thing I do want to push is there was a lot of questions from this group about genetic testing, a lot of questions. And I think maybe that comes with early awareness because those who are at risk are wanting to know more. And we do have a session coming up with a genetic counselor from Myriad later this month on genetic counseling. The last week of September is not only still ovarian cancer awareness month, but it leads into breast cancer. And so that week is hereditary cancer. And so we are doing something with Myriad then.
Oh, that's great.
Yes. I want to thank you so much for your time, Dr. Wethington. You had an enormous amount of information that you shared, and there was a huge following. So I know that this was important to people out there. And I encourage everyone who's out there to take what you learned today and go back into your communities and share this information, whether it's in person or online. And have a great afternoon. Thank you so much.
Bye, everybody.